Good day. This is Chapter 9, Musculoskeletal Disorders. The musculoskeletal system is composed of bones of the skeletal system, muscles, joints, cartilage, tendons, ligaments, and other connective tissue to help bind and support structures of the body. Bones form the skeletal system and provide support and protection for the body, especially when it's in an upright position. Bone has important metabolic functions related to metabolism of calcium and storage. It contains bone marrow, where new blood cells are produced through a process called hematopoiesis. Bones are typically classified by shape. Long bones such as the humerus and femur consist of a long hollow shaft with two bulbous ends. Short bones are typically square-like and found in places like the wrist and the ankle. Flat bones are relatively thin and curved and often found in the skull. Irregular bones, which have many projections and vary in shape, are represented by bones like those in the vertebrae and the mandible. Each bone has unique markings. The lines, ridges, process, or holes act as landmarks for attachment of tendons and passage of the nerves and the blood vessels. Bone is special connective tissue consisting of matrix and bone cell. Bone tissue or osseous tissue is different from other tissue in the body. Bone is hard and many of its functions depend on that characteristic hardness. Bone is also dynamic in that its shape is able to adjust to accommodate stresses. The bone matrix. The bone matrix is osseous tissue, which is connective tissue, and like all connective tissue, it contains relatively few cells and large amounts of matrix. The matrix is composed of collagen fibers and calcium phosphate salts to help provide its strong, rigid structure. An osteocyte is the primary cell of mature bone. It's the most common type of bone cell. Each osteocyte is located in a small cavity in bone tissue called a leucana. Osteocytes maintain the mineral concentration of the matrix. The osteoblast is the bone cell responsible for forming new bone, and it's found in growing portions of the bone. Osteoblasts do not divide. They will synthesize and secrete collagen matrix and other proteins. The dynamic nature of the bone means that new tissue is constantly formed and old, injured, or unnecessary bone is dissolved for repair or for calcium release. The cells responsible for bone reabsorption or breakdown are the osteoclast. Osteoblast and osteoclast bone activity provides homeostasis of the bone. So remember that the osteoclast is going to be responsible for reabsorption, and osteoblast help to build new cell. Osteons or Haversian systems are the units of the structure in mature bone. They're tightly arranged, running generally parallel to the long axis of the bone. At the center of each is a Haversian canal, which carries the blood vessels and the nerves. Haversian systems or osteon refer to the basic cylindrical shaped structural unit of that compact bone. The osteons are closely packed with osteocytes, and they're lined up with concentric rings. This makes this hard, dense structure for those compact bones. Osteocytes themselves are living cells, so they need nutrition. The Haversian canal is a series of tubes in the outermost region of the bone that allows the blood vessels and the nerves to travel through them to supply the osteocytes with that nutrition. The main function of this system is to supply oxygen and nutrients to the bone cell. This is the central canal that is responsible for nerve supply and vascular supply to the bone. So it's called the osteon or Haversian system. Bone tissue consists of two types. Compact bone is formed when many of those Haversian systems are tightly packed together to produce this strong, rigid structure to form the outer covering of the bone. Cancellous or spongy bone is less dense, and it forms the interior part of the bone. The spongy bone doesn't have the Haversian system, and it's made up of plates bone bone bordering cavities that contain marrow. The bone is covered by periosteum. This is a fibrous connective tissue, and the periosteum has the osteoblast, blood vessels, nerves, and lymphatics which penetrate into the canals in the bone. When the periosteum is stretched or torn, the client is going to feel severe pain. Lining the inside of the bone, adjacent to the medullary cavity, is a layer of bone cells called the endosteum. These bone cells cause the bone to grow, repair, and remodel throughout life. The endosteum contains osteoblasts. Remember, osteoblasts are bone-building cells. They create new bone cell. Bones are organs that consist primarily of bone tissue, referred to as osseous tissue. And we talked about this earlier. It's a type of connective tissue with collagen matrix that is mineralized with calcium and phosphorus. There's several different types of tissue in the bone, including two types of osseous tissue. So we have two types of osseous tissue, and they are compact bone tissue and spongy bone tissue, also called cancellous. The compact bone tissue forms the hard outside layer of the bone. Cortical bone tissue gives bone the smooth, dense, solid appearance. Spongy bone tissue fills part or all of the interior of many bones. Both compact and spongy bone tissue have the same type of cells, but they differ in how the cells are arranged. The cells in the compact bone are arranged in multiple columns, whereas the cells in the spongy bone are loose and open. The cellular differences explain why cortical and spongy bone tissue have different structures. Bones also contain several other tissues, including blood vessels and nerves, and in addition, bones contain bone marrow and periosteum. Bone marrow is a soft connective tissue found inside the marrow cavity. There's two types of marrow in adults: yellow bone marrow, which consists mostly of fat, and your red bone marrow. All the marrow is red in newborns, but by adulthood, much of the red marrow changes over to yellow. In adults, red marrow is found mostly in the femur, the ribs, the vertebrae, and the pelvic bones. Red bone marrow contains hematopoietic stem cells that give rise to red blood cells, white blood cells, and platelets in the process of hematopoiesis. Periosteum is a tough fibrous membrane. It covers the outer surface of the bones to provide a protective covering for cortical bone tissue. It's also the source of new bone cell. The bone tissue is composed of different types of bone cells: osteoblasts, osteocytes, and osteoclasts. So as discussed, the osteocyte is the primary cell of mature bone and the most common type of bone cell. They're located in that cavity in the bone tissue called the lacuna. The osteocytes maintain the matrix. The osteoblast is responsible for formation of new bone. So it's helped forming the new bone, and it's found in those growing portions of the bone. Remember that the osteoblasts synthesize and secrete collagen, matrix, and other proteins. The cells responsible for bone resorption or breakdown are osteoclasts. Osteoblasts and osteoclasts help provide the homeostasis of the bone. The osteoblasts and the osteoclasts' activity depends on two hormones: calcitonin and parathyroid hormone. The calcitonin stimulates the osteoblast, or the cell responsible for new bone growth, And parathyroid hormone stimulates the osteoclast, which is the cell responsible for resorption or breakdown. Osteogenic cells are undifferentiated stem cells. They are the only bone cells that can divide. When they do differentiate and develop, they form osteoblasts. Bone is active tissue. It's constantly remodeled by the work of the osteoblast, that new bone cell, and osteoclast, that reabsorption or breakdown of the old. The osteoblast continues to make new bone, and the osteoclast continues to break down the bone. This allows for repair of the bones consistently, as well as homeostasis of the minerals that are in the blood. Long bones, characterized by a shaft that is much longer than it is wide and a round head at the end of each shaft, are made mostly of compact bone with small amounts of spongy bone and marrow. Most bones of the limbs, including those of the fingers and the toes, are long bones, like the humerus or the femur. A typical long bone consists of the diaphysis, a thin shaft between the two larger ends, or epiphysis. The diaphysis is formed of compact bone surrounding a medullary cavity containing marrow. The metaphysis is the area where the shaft broadens to the epiphysis. Changes in bone density or thickness happen any time under the influence of hormones such as the growth hormone, parathyroid hormone, or cortisol. The stress, weight bearing, or muscle tension placed on the bone can also affect the balance between osteoblastic and osteoclastic activity. With aging, bone loss is accentuated, resulting in a decrease in the bone mass and the density. Osteoporosis is loss of bone density caused by loss of calcium salts and is common in older people, especially women. The epiphysis is spongy bone covered by compact bone. The end of each epiphysis is covered by hyaline cartilage. The cartilage facilitates movement at the points of articulation between the bones. The epiphyseal cartilage or growth plate is the site of longitudinal bone growth in children and adolescents. This growth is promoted by growth hormone and sex hormones. Longitudinal bone growth stops when the epiphyseal plate ossifies during adolescence or early adulthood. The epiphyseal plate is referred to as the epiphyseal line. Following ossification or closure, no further bone growth will occur after that phase in the length. All right, now we're moving on to skeletal muscle. Skeletal muscle has four basic functions. It can help move the body through muscle contractions. It can help keep the body in position by maintaining muscle tone. It helps stabilize joints and prevent excessive movement. And it helps maintain body temperature by helping us produce heat through muscle contractions. Skeletal muscle is under voluntary control. However, some muscle activity can occur without deliberate intent. Things like respiratory movement, which we have respiratory muscles that help with that, postural reflexes, blinking, shivering, or certain facial expressions. Skeletal muscle is striated muscle, and this means that we have these bundles of muscle fiber that are covered by connective tissue. The striated appearance comes from the arrangement of the actin and the myosin filament within that muscle. Actin and myosin are both proteins found in every type of muscle tissue, and they help work together to generate muscle contraction and movement. Muscle tissue is supplied generously with nerves and blood vessels to help fulfill its function. Skeletal muscle can contract and relax mechanically and move the body. Messages from the nervous system help to stimulate these muscle contractions. During exercise, blood vessels in the muscle are dilated, which promotes blood flow to the muscle, increasing the supply of oxygen and nutrients, glucose and fatty acids to provide energy for the muscle to contract and to remove any metabolic waste. As the muscle is stimulated to contract, this efferent impulse, or that exit outgoing motor impulse, is conducted along that motor neuron to the muscle. Each muscle fiber in the muscle receives the stimulus to contract at the same time. At the neuromuscular junction, the chemical what is released? Okay, acetylcholine. Good, if you got that. It's released there. The mechanism of muscle contraction starts at that neuromuscular junction, and it ends with the actual contraction of the skeletal muscle fiber. The chemical reaction causes the muscle fibers to reorganize themselves in a way that helps shorten the muscle, and that's the actual contraction there. When the nervous system signal is no longer present, then the chemical process reverses itself and muscle fibers rearrange again, and that allows the muscle to relax. There are limited amounts of oxygen bound to myoglobulin and stored in the muscle fiber. Myoglobulin is a red oxygen binding protein similar to hemoglobin, and it's present in the muscle cell. Glycogen, a stored form of glucose, is also stored in the muscle. The muscle can be attached directly to the periosteum of a bone, but more often connective tissue covering the muscle extends to form a cord-like structure or tendon that attaches to each end of the muscle of the two bones, and that helps articulate at the joint. So it helps with that movement at the joint. It creates strength there. Skeletal muscle cells don't undergo mitosis. Therefore, that process cannot be used to enhance muscle activity or help replace any muscle that's been damaged. There are three types of connective tissue covering of the skeletal muscle: the epimysium, which surrounds the entire muscle; the perimysium, which surrounds the fascicles or the small bundle of muscle fibers; and the endomysium, which surrounds the individual muscle fibers or cells. The motor neuron of the spinal cord and all the muscle fibers it stimulates are called the motor unit. At the neuromuscular junction, where what is released? Acetylcholine. This is where the synapse between the end of the motor nerve and the receptor site in the muscle fiber is located. And the chemical transmitter, what is it? Yes, acetylcholine is released. Following its release and the subsequent muscle contraction, acetylcholine is inactivated by the enzyme acetylcholinesterase. So neuromuscular transmission is the process that converts the nerve impulse into a muscle contraction, and it's essential for proper functioning of the body's muscles. Whenever the nerve is stimulated, that acetylcholine is going to be released. Eventually, it's going to rupture and go into the neuromuscular junction area, bind to the receptors on the muscle membrane, and that's going to lead to an action potential that will produce the muscle contraction. So let's talk about it a little bit deeper. The neuromuscular junction is the point where the motor nerves join the skeletal muscle and the nerve impulse or the action potentials are transmitted from that nervous system to the skeletal muscle. The mechanism of the muscle contraction will start at that neuromuscular junction and end with the actual contraction of the skeletal muscle fiber. So we have the arrival of the action potential from the motor neuron at the presynaptic terminal. This presynaptic terminal is at the motor neuron, and it has a lot of synaptic vesicles there that store the neurotransmitter acetylcholine. It also stores mitochondria, which is used for ATP, which will need a lot of ATP in order to synthesize this acetylcholine. All right, so we have the arrival of this action potential at the presynaptic terminal, and that causes depolarization of the presynaptic terminal. Now, this allows the cell or the neuron to open up, and we get this influx of calcium. Okay, and what calcium is going to do is cause the release of the neurotransmitter into the synaptic cleft, and eventually that neurotransmitter acetylcholine is going to attach to the postsynaptic receptors. As that occurs, what we have is a muscle action potential that now is going to travel down. As that muscle action potential travels down, it causes activation of a second messenger. and calcium is released from the sarcoplasmic reticulum, which causes the contraction to actually occur or the power stroke. Acetylcholine cannot remain in that area because if it does, it's going to cause continuous contraction. So now we'll have muscle relaxation. The calcium is going to be moved back into the sarcoplasmic reticulum, and acetylcholinesterase is going to break down the excessive acetylcholine. Both the contraction and relaxation require ATP or energy for this process to occur. So that kind of explains why we have so much mitochondria in that presynaptic terminal. We also need that mitochondria to produce that neurotransmitter acetylcholine. If the action of the neuromuscular junction is interrupted for any reason by some toxin, the action of the acetylcholine release and uptake can be disrupted. Aerobic respiration producing ATP can be maintained in muscle fiber as long as there's enough oxygen available in the myoglobin and the blood. If the supply of oxygen does not meet the demand, then anaerobic respiration begins using glucose as the energy source, causing an oxygen debt, or the amount of oxygen required to restore the muscle cell to its normal resting state. Conversion of lactic acid to pyruvic acid, glucose, or glycogen, and replenishing the stores of ATP will start to occur. Anaerobic respiration produces lactic acid instead of carbon dioxide. Accumulated lactic acid in the body can cause muscle pain and cramping during and immediately after exercise. The muscle cramp is pain, and it comes from strong muscle contractions or spasms caused by irritation from the metabolic waste. Muscle spasms reduce the blood flow and cause ischemic pain. Muscle soreness and pain that appear a day or so after strenuous exercise are often the result of minor damage to the muscle cells and inflammation. During periods of strenuous physical activity and anaerobic metabolism, excessive lactic acid goes into the blood, which can lower the pH and lead to metabolic acidosis. Joints are the area where two or more bones meet. Most joints are mobile, which allows the bone to move. Connective tissue covers the muscle, known as perimysium, and it extends to form a cord-like structure or tendon that attaches each of the muscle to the two bones that articulate at the joint. At the joint, one bone remains fixed, forming the origin of the muscle, while the other bone attached to the same muscle is moved by the muscle contraction. It is called the insertion. Ligaments form a direct attachment between two bones. The function of a joint is accomplished by the tendon and the ligaments, composed of collagen fiber arranged in bundles, a structure that can withstand considerable stress. Ligaments are strong, tough, elastic bands of connective tissue that go around the joint to provide support and limit the joint's movement. Ligaments help connect the bones together. Tendons are another type of tough connective tissue. On each side of the joint, they attach to the muscles to control the movement of the joint. Tendons connect the muscle to the bone. Tendons and ligaments have little blood supply, so it takes a long time for either one of these to heal. It can be slow and difficult. Joints vary in the degree of movement allowed. Synarthrosis, represented by the sutures in the skull, are immobile types of joints. Amphiarthrosis are slightly movable joints. These joints are in which the bones are connected by cartilage or hyaline cartilage, and examples of these type of joints include the junction of the ribs, the sternum, and the symphysis pubis. So if you notice your ribs, they kind of float there and they're connected together and they work together like an organ. If for some reason you had a flailed chest or multiple rib fractures, it could interfere with that ability of how they float together and your ability to breathe. Diarthrosis or synovial joints are freely movable joints. These are the most common type in the body. Different types of diarthrosis allow a variety of movement. For example, a hinge joint that provides flexion and extension is found at the elbow, whereas a ball and socket joint at the shoulder provide a wide range of motion, including rotation. In a synovial joint, ends of the bones are covered with hyaline or articular cartilage. This provides a smooth surface and cushion during movement. With aging, that cartilage degenerates, becomes thin, and causes difficulty with movement and changes in the alignment of the bones. The space between the articulating ends of the bones is filled with a small amount of synovial fluid that helps facilitate movement. The synovial fluid prevents the articular cartilages on two surfaces from damaging each other and provides nutrients to the articular cartilage. The synovial fluid is produced by the synovial membrane. The synovial membrane is well supplied with blood vessels. It lines the joint capsule to the edge of the articular cartilage. The articular capsule is composed of synovial membrane and its outer covering, that fibrous capsule that extends into the periosteum of each articulating bone. Capsule is reinforced by ligaments that strap across the joint that link the two bones to support the joint and prevent excessive movement of the bone. The knee has additional moon-shaped fibrocartilage pads termed lateral and medial menisci. These help stabilize the joint. Bursae are fluid-filled sacs composed of synovial membrane located between the structures such as tendons and ligaments, and they act as additional cushions in the joints. The TMJ is the only movable joint in the skull and the face. It has two synovial cavities and central articular cartilage of dense collagen tissue. In a synovial joint, that articular or hyaline cartilage provides that smooth surface and cushion during movement. Now, synovial joints have the most freedom to move. They're made of a cavity in one bone and another bone that fits into it. They have that slippery hyaline cartilage that covers the end, and that helps make up this synovial joint. The synovial membrane, which is that fluid-filled sac that helps protect the joint and lines that space between the bones. So all that is giving it that movement or that freedom of movement. People exposed to trauma, tumors, or metabolic disease that are suspected of having bone abnormalities can be evaluated using X-ray and bone scans. Electromyograms or EMGs help measure the electrical charge associated with the muscle contraction and help differentiate between a muscle disorder and a neurological disorder. A biopsy of a muscle is required to confirm the presence of certain muscular disorders such as muscular dystrophy. Joints can also be visualized through arthroscopic procedures or by MRIs. Synovial fluid can also be aspirated and analyzed to look at whether inflammation, bleeding, or infection is present. We can also look at calcium phosphate and parathyroid hormone levels, as they may indicate metabolic changes, perhaps secondary to kidney disease or parathyroid hormone imbalances. These parathyroid hormone imbalances can occur in someone that had the thyroid out if the parathyroid gland itself was damaged. Muscle disorders may be checked by determining levels of components such as serum creatinine kinase in persons that have a muscle disorder or a muscle disease. The serum creatinine kinase can be elevated because it's indication of inflammation. A fracture is a break in the structure and continuity of the bone. A fracture can be full or partial in the continuity of the bone tissue. Fractures can occur in any bone in the body, and they're usually the result of some high impact force or stress. They can also be a sign of certain conditions such as osteoporosis or cancers. Fractures can be classified in several ways, as complete or incomplete. A complete fracture happens if the bone is broken in two or more separate pieces. An incomplete fracture occurs when the bone is only partially broken. Examples of an incomplete fracture include a green stick fracture, common in soft bones of children, where the shaft of the bone is bent and the cortical bone or the outer layer of the compact bone is torn on one side but doesn't extend all the way through the bone. An open or compound fracture happens if the skin is broken and the bone fragments are sticking outside. The fragments can be angled and protrude through the skin. In open fractures, there's more damage to the soft tissue, including the blood vessels and the nerves, and a greater risk for infection. In a closed fracture, the skin is not broken at the fracture site. We can also have a number of fracture lines. Simple fracture is where we have a single break in the bone and the bone ends and maintains its alignment or its position. In a segmental fracture, the bone break occurs where there are several large bone fragments that separate from the main body of the fractured bone. In a comminuted fracture, there are multiple fracture lines and bone fragments. In a compression fracture, this happens commonly in the vertebrae, and this can occur when the bone is crushed or collapses into small pieces. We also have impacted fracture. This can happen if the bone is forced or telescoped into an adjacent bone. For example, the neck of the femur is crushed against the pelvis. Pathological fractures result from a weakness in the bone structure because of conditions such as a tumor or osteoporosis. This break occurs spontaneously with very little stress on the bone. So this can actually happen in some kids who have bone softening or issues with their bones, and just from like changing a diaper or rolling the child over. Also, sometimes we'll see like pelvic fractures in older adults when they have something like multiple myeloma or some other condition that causes these pathological fractures, and very little movement is going to occur here and cause that bone to break. With a stress fracture, this results from repeated excessive stress, commonly on things like the tibia, the femur, or the second and third metatarsals. Depressed fracture. This occurs in the skull when a broken section is forced downward or inward on the brain. We have transverse fracture, and this is a fracture across the bone. A linear fracture, which is a break along the axis of the bone. Oblique fractures, where there's a break at an angle to the diaphysis of the bone. And then spiral fractures, a lot of times we'll see this in infants. This is usually recognized as child abuse, where we have this break that angles around the bone, and it's usually caused by some twisting injury. So somebody grabbed the bone and twisted it, and it caused a spiral fracture. So again, here's a picture with all the different fractures on it. Oblique, comminuted, you can see the small pieces there. The open fracture, okay, and so on and so forth. So take a good look at that chart in your book and be able to recognize. Now this Colles fracture, this wrist distal fracture, this is common in older people. A lot of times people will put their hand out as they're going to fall, and it's the bracing of that fall that causes that distal fracture in the wrist there, and it's called a Colles fracture. Each healing process starts with a hematoma formation in the inflammatory phase. This results from the blood vessel disruption upon injury and fracturing of the bone. During this process, blood is released from the broken or torn vessels in the periosteum, osteones, or medullary cavity and clots into what we call a fracture hematoma. Even though broken blood vessels promote an increase in nutrient delivery to the site of the vessel, as we see usually during the inflammation process, the disruption of the blood flow to the bone results in death of bone cell around that fracture. Necrosis occurs at the end of the broken bone because of the torn blood vessels, and they're not able to continue the delivery of those nutrients. Edema then causes stretching of the periosteum if it's intact and swelling of soft tissues causing severe pain. Bradykinin and other chemical mediators released also contribute to the pain. A clot will form at the fracture site. Systemic signs of inflammation may occur here. Following the fracture, secondary healing begins, and that consists of 5 steps: hematoma formation, granulation tissue formation, procallus formation, bony callus formation, and bone remodeling, all shown in the diagram. Several factors can affect the healing process. In children, the fractures usually will heal in about a month. In adults, about 2 months. In an older person, it can require several months to heal. Additional factors also can affect the healing process: the amount of damage done to the bone or the soft tissue, the amount of inflammation, any prolonged inflammation or extensive damage to the periosteum or the blood vessels can impair the healing. If necessary, the bones must be realigned in the proper position before healing can begin. Immobilization of the bone is necessary to prevent disturbance or damage to the developing fragile bridge that we talked about that is going to develop from that procallus. Secondary problems such as foreign materials or infection at the site can also delay the healing process. Fracture repair is delayed in the older person and in any client that has circulatory problems, anemia, diabetes mellitus, or other nutritional deficits, as well as anybody taking drugs like steroids. Complications can affect the healing process in a client who sustains severe injuries. Muscle spasms may occur as local pain and irritation cause strong muscle contractions at the fracture site. The muscle spasms can pull the bone fragments out of position, causing angulation or deformity, rotation of the bone, or overriding of the bone pieces. Abnormal movement of the bone causes more soft tissue damage, bleeding, and inflammation. Infections such as tetanus or osteomyelitis can develop and are a threat, especially with compound fractures or when surgical intervention is required. In some cases, precautions would include wound debridement, application of a windowed cast, tetanus booster shots, and prophylactic antibiotic therapy. Ischemia is a complication that can also develop in a limb following treatment with a cast, as the edema increases during the first 48 hours after the trauma and the limb is compressed by the cast. If the peripheral area, such as the toes or the fingers, become pale, cold, or numb, or if the peripheral pulse has decreased or is absent, it's likely that the cast is becoming too tight and compromising the circulation in the limb. Compartment syndrome can occur and the cast must be released quickly to prevent secondary tissue damage. It's also important during the healing that the cast not become too loose as edema decreases and the muscle atrophies. The newly formed procallus can become weak and break down if there's any bone movement. Fat emboli are also a risk, especially in the long bones for someone that's immobilized, and boys are more at risk. Fatty marrow can escape from the bone marrow into the vein within the first week of an injury. This is more common in clients with fractures of the pelvis or the long bone, like the femur, especially when the fracture site has not been well immobilized during transportation or immediately after the injury. Fat emboli will travel to the lungs where they cause obstruction, extensive inflammation, and respiratory distress syndrome. Indications of fat embolus would be behavioral changes, confusion, and disorientation associated with cerebral emboli in combination with respiratory distress and severe hypoxia. Nerve damage can also occur with severe trauma or tearing of the periosteum. Also, failure to heal or non-union can occur, or healing with a deformity or a malunion can also result if the bone is not stabilized with the ends closely approximated and aligned. Fractures in or near the joint may have long-term residual effects such as osteoarthritis, or it can stunt the growth if the epiphyseal plate is damaged in a child. As discussed earlier, compartment syndrome is a serious condition that occurs when there's too much pressure on the inside of a muscle compartment. The fascia is not able to expand, so swelling in the compartment can result in increased pressure inside that compartment. This would result in injury to the muscles, the blood vessel, and the nerve inside that compartment. The increase in the pressure can cut off blood flow to the compartment, resulting in loss of oxygen to the tissue, ischemia, and cellular death or necrosis. Compartment syndrome can develop develop shortly after a fracture occurs when there is more extensive inflammation and edema, such as with crush injuries. Increased pressure of fluid within the fascia, the non-elastic covering of the muscle, compresses nerves and blood vessels, leading to severe pain and ischemia or necrosis of the muscle. Pressure effects may be aggravated by a cast. This could also occur in someone that has a burn, where the burn goes all the way around the leg, the entire circumferential area, and we may have to cut either the fascia there or do an escharotomy to try to relieve that pressure. So it's the same principle here. This slide is discussion treatments of fractures. So we would use closed reduction to restore the bone position, or open reduction with surgery, screws, pins, and rods to try to help align the bone fragments. A dislocation occurs when two bones are separated at the joint and there's a loss of contact between the articulating bone surfaces. Usually one of the bones is out of position while the other one remains in its normal position. We can also have something called subluxation. For instance, if the bone is only partially displaced with partial loss of contact between the articulating surfaces, then the injury is termed subluxation. An underlying disorder such as muscular disease or rheumatoid arthritis or other damage such as torn ligaments can predispose a person to dislocation. Dislocations cause considerable soft tissue damage, including damage to ligaments, nerves, and blood vessels as the bone is pulled away from the joint. Severe pain, swelling, and tenderness can develop. Bleeding and inflammation may result. Deformity and limited movement are usually evident. The diagnosis is confirmed by x-rays. If this continues to happen over and over, the person may need some sort of surgery to correct it. Healing is going to be slow if the ligaments and the soft tissue are extensively damaged. So again, this is just showing you the two different examples of dislocation versus subluxation. Remember, with dislocation, the two surfaces are completely displaced from one another, so there's no contact at all. However, in subluxation, we'll have partial contact there with the surfaces. Now we're talking about sprains and strains. A sprain is a tear in a ligament, and a strain is a tear in a tendon. Ligaments and tendons support the bones in a joint and can be easily torn when excessive force is exerted on the joint. In an avulsion, the ligament or the tendon becomes completely separated from their bony attachment. Sprains and strains are painful and are accompanied by tenderness, marked swelling, discoloration because of hematoma formation. Bleeding into the joint capsule delays healing. Strength and range of motion in the joint are limited. Immobilization is often used to prevent tissue damage and promote healing. Diagnosis typically requires an X-ray or other test to rule out a fracture and determine the extent of damage. A tendon or ligament requires about 6 weeks to heal before it is strong again. Muscle tears are tears along the muscle itself or at the points of attachment. They occur as a result of direct trauma or overexertion. The number of traumatic and overuse injuries has increased along with the rising number in fitness and recreational activities. Predisposing factors include inappropriate or inadequate equipment, training, or warm-up techniques, more aggressive approaches to sports, and failure to allow minor injuries to heal completely before we continue the activity again. Minor injuries result from excessive use or abuse, especially of joints, and are also increasing. For example, tennis elbow, in which inflammation develops at the junction of the forearm muscles within the humerus. Repetitive strain injuries are injuries that develop over a period of time where the same movement is constantly repeated. Repetitive strain injuries refers to disorders that affect muscles, tendons, and nerves that develop over a period of time. The cause seems to be the repetitive, forceful, or precision movement, many of which are associated with our work-related activities. but it can also happen through sports such as golf and certain exercise. Repetition of certain movements interferes with circulation to the area and can damage soft tissue and have cumulative effects. Most injuries affect the upper body. Work-related activities such as repetitive lifting of merchandise, pivoting on an assembly line, retrieving and shelving library materials are associated with higher risks of these types of injuries. The result is pain, weakness, and numbness causing disability and interference with sleep. Examples include tendonitis, inflammation or injury of the tendon, and sheath or compression of a peripheral nerve, as seen in carpal tunnel syndrome. In carpal tunnel, the median nerve is compressed at the wrist between the tendons and the transverse carpal ligament. So this repeated movement of using that keyboard, also like if you're a massage therapist, repeatedly using those hands, running, jogging, you work at Amazon, you're stocking shelves, all of these things can lead to overuse injuries. For joint injuries, diagnosis would require a history, x-rays, and arthroscopic examinations to look inside. It also may require something like an MRI. Additional methods of treatment may include rest, immobilization, compression, elevation, all things to reduce the inflammation, to reduce the pain, the swelling, all right, NSAIDs, PT, and massaging that surrounding tissue. Repeated injuries usually end up resulting in scar tissue, and that scar tissue is going to replace the normal structure, and that's going to impair the mobility there. It can cause permanent joint damage, and it can cause development of osteoarthritis. For example, repeated tears in the knee ligaments appear to cause early development of osteoarthritis. Shoulder pain or damage to the rotator cuff can be a result of excessive swinging from motions like that we use when we play golf, tennis, or hockey, or if we're a professional painter and we're painting ceilings or walls, even if you were just painting, your house over time. All right, and those kind of injuries can cause something called tendonitis. Muscle tears are more common, and they lead to things like hematoma and scar tissue formation. A first-degree muscle tear involves only a small percentage of the muscle. The pain would be mild, and we wouldn't have much in the way of loss in strength or range of motion. With the second degree, we see a larger tear. It involves a lot of the muscle, but it's not a complete tear. The pain can be severe, and the muscles partially contracted with loss of strength and range of motion. In a third-degree tear, we have a complete tear across the width of the muscle, and the muscle is not able to contract. Internal bleeding can occur, and surgery may be required in order for it to heal properly. Activity that involves the use of the muscle should stop when a tear occurs. An example of a third-degree tear requiring surgery may be tearing of the gastrocnemius or the hamstring. In all cases, any scar tissue that forms will reduce the flexibility and the strength of the muscle. All right, next we'll be discussing the different bone disorders. So osteoporosis, this is a metabolic bone disorder, and it's characterized by decreases in the bone mass and the density, along with the loss of bone matrix and mineralization. Remember, that's what makes that bone hard, right? Although women have a higher risk of osteoporosis, a significant number of men have also been diagnosed. Osteoporosis can occur in two forms: primary, which includes postmenopausal, senile, or idiopathic osteoporosis, and secondary, which affects both men and women and follows a specific primary disorder like Cushing's syndrome. So sometimes you'll see that in clients who take excessive amounts of steroids for one reason or another. During the bone remodeling process, bone resorption exceeds bone formation, leading to thin, fragile bones subject to spontaneous fracture, particularly in the vertebrae. Bone density and mass are reduced and results in loss of compact bone. Osteoporosis affects bones that have higher proportions of cancellous bone, such as the vertebrae and the femoral neck. This can lead to kyphosis and scoliosis. Compression fractures of the vertebrae have several obvious effects. Back pain is a common sign of osteoporosis. In the early stages, these conditions may be asymptomatic but can be diagnosed using various bone density scans and x-rays to show the bone changes. Osteopenia occurs as bone density slowly becomes lower and is considered a midpoint on the progression to osteoporosis. A number of factors that predispose people to osteoporosis include being over the age of 50. Osteoporosis is common in older people, especially postmenopausal women with estrogen deficiencies. Osteoblastic activity is less effective with advancing age, so this is the creation of that new bone. Decreased mobility or sedentary lifestyles, so when we don't put enough stress on the bone, this can contribute to osteoporosis. So mechanical stress exerted on the bone by muscle activity is essential for that osteoblastic activity to occur. When we have a client that has a decreased level of mobility, which occurs with aging, but also when clients are on bed rest for prolonged periods of time due to a chronic illness, or maybe have limited activity because of something like rheumatoid arthritis. We can see this occur. One limb or one area of the bone can also be affected by osteoporosis if that area is immobilized because of conditions such as a fracture, and this can cause disuse osteoporosis. Other factors that contribute to a risk for osteoporosis are things like hyperparathyroidism, Cushing's syndrome, or intake of catabolic glucocorticoids such as prednisone. We'll also see people develop osteoporosis who have deficits of calcium, vitamin D, or protein related to either their diet or some sort of deficit in childhood or some sort of malabsorption disorder. Cigarette smoking can contribute to osteoporosis, and other people at risk would include people that have a small, light bone structure, such as Asian descendants or some Caucasian people as well. Also, excessive intake of caffeine can result in osteoporosis. So you see a number of treatments, dietary supplements, Fosamax, Boniva, all these things that we might have to do, weight-bearing exercise, surgery if they're having kyphosis or some other issue. Rickets and osteomalacia can result from a deficit of vitamin D and phosphates. These are required for bone mineralization. This can occur with dietary deficits, malabsorption, prolonged intake of phenobarbital, like in someone that has a seizure disorder, or lack of sun exposure. The result would be soft bone and rickets in children. Vitamin D is required to absorb calcium, and lack of calcification of the cartilage forming at the epiphyseal plate leads to weak bones, deformities, and bow legs. The child's height is usually below normal. In adults, osteomalacia occurs in those with poor absorption of vitamin D or sometimes calcium, causing soft bones resulting in compression fractures. Renal rickets refers to osteomalacia associated with severe renal disease because the kidneys help activate that vitamin D in the body. Paget's is a progressive bone disease that occurs in adults over the age of 40. The exact cause is not known. In this disease, we have excessive bone destruction with replacement of bone by fibrous tissue and abnormal bone. Structural abnormalities are usually evident on x-rays, and we can see enlargement or thickening in the long bones, the vertebrae, the pelvis, and the skull. Pathological fractures are common. If vertebrae are affected, we'll see compression fractures and kyphosis. If the skull involvement occurs, this can cause things like increased cranial pressure, headaches, and compression of the cranial nerves. It can also lead to cardiovascular disease and heart failure. Osteomyelitis is a bone infection usually caused by bacteria and sometimes fungi. The bacteria or microorganism enters the blood from an infection anywhere in the body and quickly spreads to the bones. This can also occur as a result of surgery. There could be both local and systemic manifestations and may include the following: local inflammation and bone pain, fever, excessive sweating, chills, general malaise. Treatment may include things like antibiotics or surgery. Abnormal curvatures of the spine. Curves formed by the vertebrae help the spine absorb stress and help with the action of gravity. Curves can become misaligned or exaggerated, resulting in three main types of curvature disorder: lordosis, kyphosis, and scoliosis. The three types of abnormal curvature share some common causes, such as osteoporosis or arthritis. Other causes are specific to the disorder. Lordosis, also referred to as swayback, is characterized by the spine curving significantly inward at the lower back. Kyphosis, seen in many older women with osteoporosis, is often referred to as hunchback or humpback and is characterized by an abnormally rounded upper back. This occurs around the thoracic area and can sometimes cause difficulty with breathing for them. Scoliosis is characterized by either an S or C-shaped sideways curve to the spine. Specific causes of the most common form of this abnormality are generally not known. It does tend to run in families, and in some cases, we'll see that disease, trauma, or congenital defects are involved. This slide is comparing kyphosis on the left to lordosis on the right. Lordosis is characterized by the spine curving significantly inward at that lower back, and some of the specific causes of lordosis include achondroplasia, obesity, discitis, or slipping forward of the vertebrae. In kyphosis, we have abnormally rounded upper back in that thoracic area, and some causes include poor posture, spina bifida, congenital defects, tumors on the spinal cord or infection, and Scheuermann disease. Again, the kyphosis can put pressure on that thoracic area and cause difficulty with breathing. So this is listing causes of the lordosis, which we just talked about. Causes of kyphosis, which we also talked about. Treatment for these are going to include medication for pain and inflammation, weight loss if it's caused by obesity, potentially wearing a brace to try to help straighten the area, exercises, physical therapy, and surgery. The majority of primary bone tumors are malignant. Bone is a common site of secondary tumors, especially in the spine and the pelvis. Metastatic bone tumors are secondary to malignant tumors, and these usually occur from breast, lung, or prostate cancer. I know prostate cancer for a fact really loves the bone. So sometimes it's these that are metastasizing to the bone and causing additional problems. Both types of tumors grow quickly and metastasize to the lungs in the early stages of tumor development. Sometimes the tumor is revealed through pathological fractures. Bone pain is a common symptom and is typically a constant, steady pain even when the client's at rest, as well as with activity that would gradually increase in severity. Sometimes the person will feel increased pain at night as well. Primary tumors are known as sarcomas. Osteosarcoma is a primary malignant neoplasm that usually develops in a metaphysis of the femur, tibia, or fibula in children or young adults, especially males. Ewing sarcoma is another malignant neoplasm common in adolescence that occurs in the diaphysis of long bones. Chondrosarcomas arise from cartilage cells and are more common in adults over the age of 30. These tumors develop more gradually on the pelvic bone or shoulder girdle at the points of muscle attachment and eventually metastasize to the lung. Pain develops late and the tumors often remain silent until they are well advanced. Because these tumors can metastasize to the lungs early in the course of the disease, We're a little aggressive with treatment when possible. So we may remove the tumor if possible by excising it. We can do surgical amputation if the excision is not feasible, or we may have to do chemo to reduce the metastatic activity of the tumor. Muscular dystrophy is a group of inherited disorders characterized by degeneration of skeletal muscle. Disorders differ in the type of inheritance, the area affected, the age of onset, and the rate of progression. Duchenne's muscular dystrophy is the most common type, and it typically affects young boys. It is considered an X-linked inheritance and has been demonstrated in many cases of Duchenne's muscular dystrophy. In Duchenne's muscular dystrophy, we have a metabolic defect, a deficit of dystrophin, which is a muscle cell membrane protein that leads to degeneration and necrosis of the cell. The skeletal muscle fibers are replaced by fat, fibrous connective tissue, causing that hypertrophic appearance of the muscle. Look at those hypertrophic calves. Muscle function is gradually lost. Cardiomyopathy is common here. Early signs appear around the age of 3 when motor weakness and regression become apparent in the child. Weakness in the pelvic girdle causes a waddling gait and difficulty with climbing stairs or attaining an upright position. The child uses the Gower maneuver shown below, by which the child pushes themselves up to an erect position by using their hands to climb up the legs. Weakness can spread to other muscle groups and eventually to the shoulder girdle. Tendon reflexes are reduced. Vertebral deformities such as kyphoscoliosis and contractures develop. Respiratory insufficiency and infections are common. The majority of clients with Duchenne's muscular dystrophy will develop cardiac abnormalities and intellectual delay. Kyphoscoliosis is a combination of kyphosis and scoliosis. This musculoskeletal disorder often causes other issues in the client, such as underventilation of the lungs, pulmonary hypertension, and difficulty performing day-to-day activities. These children can have a short lifespan. Diagnosis is based on identification of common genetic abnormalities, elevated creatinine kinase levels, EMG, and muscle biopsies. Female carriers in a family can be identified by the presence of defective dystrophin in the blood. No focus on treatment here, but just a little synopsis. There is no curative treatment. They may use exercise here, PT, to maximize function of the lungs and the body, ventilator if they go on respiratory therapy, and they continue to do genetic research on this. Okay, here you'll see the different types of treatment. Duchenne's is the one that they focus on most of the time, so I would take a good look at that and understand what the causes of that are, how we would recognize it, and what sort of symptoms we would see. Next, we're looking at primary fibromyalgia syndrome, and this is a group of disorders characterized by pain and stiffness affecting muscles, tendons, and the soft surrounding tissues, but it doesn't affect the joints. In primary fibromyalgia, the client has no obvious signs of inflammation or degeneration in the tissue. The cause is unknown and appears to be related to altered central neurotransmission, resulting in increased soft tissue sensitivity to substance P, a neurotransmitter involved in pain sensation. The onset is higher in women ages 20 to 50 years old. Predisposing factors include a history of prior trauma or osteoarthritis, and aggravating factors include sleep deprivation, stress, and fatigue. Manifestations of fibromyalgia may include the following: generalized aching pain, marked fatigue, sleep disturbances, depression. Some clients may have irritable bowel syndrome or urinary symptoms caused by interstitial cystitis. Treatment for fibromyalgia can include avoiding stress or reducing stress, regular exercise, pacing activities, application of heat or massage, and analgesics such as low doses of tricyclic antidepressants, NSAIDs, or some of the newer drugs are Lyrica or pregabalin. You notice that it has GABA in it, sort of like gabapentin, and that's going to help with that what we call neurogenic or neuropathic pain. Myositis makes your immune system attack your muscles. It's a general term for referring to severe inflammation and subsequent damage of the muscles. Diseases included in this group are polymyositis, dermatomyositis, and juvenile myositis. These are autoimmune diseases, and also included is body myositis and toxic myositis caused by medications. Depending on which type of myositis you have, you'll have a hard time moving or using your affected muscles. Symptoms include difficulty climbing stairs or lifting the arms, feeling tired after standing or walking, trouble breathing or swallowing, muscle pain and soreness that doesn't resolve after a few weeks, known elevations in muscle enzymes through blood tests like creatinine kinase or adalase. Adalase levels can be higher than normal in many conditions. For example, high levels of adalase are found in progressive muscular dystrophy and lesser elevations in polymyositis, dermatomyositis, and limb-girdle muscular dystrophy. In addition, other tests that could be ran during this time include MRIs, EMGs, and muscle biopsies. And then some treatments may include things like prednisone, azathioprine, or methotrexate. Next is joint disorders. Arthritis occurs in many forms that impair joint dysfunction, leading to various types of disabilities in all age groups. Osteoarthritis occurs when the cartilage that joins the ends of the bones in your joints gradually deteriorates. This cartilage is a firm, slippery tissue that allows nearly frictionless joint motion. If the cartilage wears down, then bone will rub on bone. Osteoarthritis has been referred to as a wear and tear disease because of this. It's a major cause of disability and absence from the workplace. In osteoarthritis, the cartilage breaks down, resulting in changes to the bone and the joint tissue. Inflammation can occur, along with pain, stiffness, and loss of flexibility. In this condition, the progression is as follows. The articular cartilage of the weight-bearing joints, especially those in the hips and the knees, is damaged and lost through structural fissures and erosion resulting from excessive mechanical stress or breakdown for unknown reason. The incidence of osteoarthritis is increasing. Genetic changes in the joint cartilage have been identified in research studies that are currently underway. These genetic changes have resulted in accelerated breakdown of the articular or that hyaline cartilage. The articular cartilage of the weight-bearing joints, especially the hips and the knees, is damaged. And as a result of that, okay, the surface of the cartilage becomes rough and warm. This interferes with the ability of the joints to easily move. Tissue damage appears to cause release of enzymes from the cells, accelerating the disintegration of the cartilage. Eventually, the subchondral bone can be exposed and damaged. Cysts and osteophytes, or new bone spurs, can develop around the margin of the bone. Pieces of the osteophytes and the cartilage break off into the synovial cavity, causing further irritation. The joint space becomes narrower, and this is easily seen on x-rays. There can be secondary inflammation of the surrounding tissue in response to the altered movement and the stress being placed on the joint. No systemic effects are present with osteoarthritis. Osteoarthritis causes inflammation, changes in the shape of the bone, and deterioration of the cartilage, and it's a primary disease affecting the cartilage. People with the condition have higher levels of inflammatory markers, which indicate inflammation, and enzymes are being released, causing tissue damage and joint deterioration. The first changes that occur in the body due to osteoarthritis affect the articular cartilage. This is the cartilage that covers the ends of those bones where they meet at the joint, and they become eroded or irregular, split, or frayed, affecting more of the joint surface. Injury or damage to the cartilage can also damage the matrix, resulting in chondrocytes multiplying and forming clusters. This leads to bony lumps to form bone spurs. Remember that chondrocytes help produce and maintain the matrix. Damage to the matrix can also cause thickening of the bone underneath the cartilage and may sometimes cause fluid-filled areas in the bone called bone cysts. There can also be inflammation of the joint's synovium. These changes occur gradually, and people start to slowly experience signs of osteoarthritis, such as pain and stiffness and limited range of motion. The primary form of osteoarthritis is associated with obesity and aging. The secondary type follows injury, repetitive use, or abuse, a common consequence of participation in sports and certain occupations. Genetic changes in joint cartilage have been identified in research studies that are currently underway. Congenital anomalies of the musculoskeletal system can also predispose a client to osteoarthritis. The large weight-bearing joints, such as the knees and the hips, are subject to injury or occupational stress and are frequently affected. Also, the joints of the fingers. Once the cartilage is damaged, joint alignment or the frictionless surface of the articular cartilage is lost, and a vicious cycle ensues. Pain is often mild with osteoarthritis and typically has a slow onset. The pain that does occur is usually aching, and it occurs with weight bearing and movement. The pain can become more severe as the degenerative process advances, and it may be unilateral. Joint movement is limited. The joint may appear enlarged and hard as osteophytes develop. If the joint is unstable and the muscles atrophy, it can put the person at risk for falling, especially if they're older. If the TMJ is involved, mastication or chewing becomes difficult. There's difficulty opening the mouth to speak or yawn, and preauricular pain may be severe. If the hands are involved, in some cases, we see bony enlargement of the distal interphalangeal joints, known as Heberden nodes. That's in your book on figure 911. Usually a little soft tissue swelling is also seen. Crepitus may also be heard as the cartilages become irregular and grate against each other. Osteoarthritis is not a systemic disorder. Therefore, there are no systemic signs or changes in the serum levels. Again, for this course, we're not really focusing in on treatment. However, if we wanted to address treatment, we would look on minimizing stress on the joint using adaptive devices, pacing activity, and then possible braces or inserts, mild exercise. Then some other treatments might be PT, acupuncture, glucosamine injections, NSAIDs, analgesics, arthrotomy to stabilize the joint, or some sort of surgical replacement. All right, next is rheumatoid arthritis. This is an autoimmune disorder causing chronic systemic inflammatory response. It's a major cause of disability. The incidence is higher in women than in men, and it increases in older individuals. In rheumatoid arthritis, we'll see remissions and exacerbations that lead to progressive damage of the joints. In rheumatoid arthritis, it often starts slow, and then we'll see symmetric involvement of the small joints, such as the fingers, followed by inflammation and destruction of additional joints like the wrists, the elbows, and the knees. In the affected joints, the first step in development of rheumatoid arthritis is an abnormal immune response. This leads to inflammation of the synovial membrane and vasodilation, increased permeability, formation of exudate, eventually causing the typical red, swollen, and painful joint. Synovitis is inflammation of the synovial membrane that lines some of the joints. It appears to be a result of the immune abnormality. The inflammation recurs and synovial cells will proliferate or rapidly grow. For the pannus formation, granulation tissue from the synovium will spread over the articular cartilage, and the granulation tissue is called pannus. It will release enzymes and inflammatory mediators that destroy the cartilage. The pannus is this abnormal thickening of the synovium or the joint lining, leading to growth at the joints, bones, and other tissue. Pannus can cause severe pain and swelling. It can cause damage to the bones, the cartilage, and nearby tissues. Mainly T cell and B cell lymphocytes are to blame for pannus formation. Cartilage erosion is also going to occur. The cartilage is eroded by the enzymes from the pannus, and in addition, nutrients that are normally supplied by the synovial fluid to the cartilage are cut off by the pannus. Erosion of the cartilage creates an unstable joint. Fibrosis may also occur in time the pannus between the bone ends and becomes fibrotic, and this limits movement. This causes calcification and the joint space is obliterated. And then ankylosis will have joint fixation and deformity if we don't treat this. During each exacerbation or acute period, inflammation and further damage occur in joints previously affected, and additional joints become affected by synovitis. Mobility is greatly impaired as the various joints become damaged and deformed. Walking will become difficult when the knees or ankles are affected. Acute inflammation leads to disuse, atrophy of the muscles, and stretching of the tendons and ligaments, decreasing the supportive structures in the unstable joint. The alignment of the bones in the joint shifts depending on how much cartilage has been eroded. Inflammation and pain may cause muscle spasm, further drawing the bones out of normal alignment. Contractures and deformity with subluxation can develop. Rheumatoid arthritis causes joint inflammation and pain, and it happens when the immune system attacks the lining of the joints called the synovium. This disease commonly affects hands or ankles, and usually the same joint on both sides of the body, such as the hands or the knees. Sometimes rheumatoid arthritis causes problems in other parts of the body, like the eyes, the heart, and the circulatory system or the lungs. The immune system releases inflammatory chemicals that attack the synovium, the tissue lining around the joint that provides fluid to help the joint move smoothly. The inflamed synovium gets thicker and makes the joint area feel painful and tender and look red and swollen, and moving the joint becomes difficult. Pannus is that abnormal growth or that thickening in the joint lining. The most common cause of pannus is rheumatoid arthritis, which causes inflammation of the synovial lining in the joints. Nodules can also form in the pleura, the heart, the valves, or the eyes. These are small granulomas on blood vessels. Iron deficiency anemia with low serum iron levels is common in these clients. This is the typical type of deformity you would see in a hand with rheumatoid arthritis. Although rheumatoid arthritis is considered autoimmune, the exact nature of the abnormality has not been fully determined. A genetic factor is present with familial predisposition. Rheumatoid arthritis seems to be linked to several viral infections, and it's more common in women than men. The incidence increases with age. Again, with rheumatoid arthritis, we'll have a slow onset. Specific manifestations may include the following. Inflammation may be apparent first in the fingers or the wrist. It affects joints in a bilateral fashion. Usually more than one pair of joints are involved. The joints will appear red and swollen. They're often sensitive to touch and painful. Joint stiffness occurs after rest, which then would ease with mild activity as the circulation improves throughout the joints. Joint movement is impaired by swelling and pain, and frequently daily activities become difficult, such as dressing, food preparation, or oral hygiene. Malocclusion of the teeth may develop from TMJ involvement as the condyle is damaged. Systemic effects of rheumatoid arthritis are marked during exacerbations and include fatigue, anorexia, mild fever, generalized lymphadenopathy, and generalized aching. Iron deficiency anemia, resistant to iron therapy. Diagnostic tests would include analysis of the synovial fluid, which would demonstrate the inflammatory process. Rheumatoid factors may also be present in the serum, but are not specific for a diagnosis. We won't elaborate too much on the treatment here since it's not required for this course, but we would want some balance between rest and activity, hot and cold applications, glucocorticoids for severe inflammation, demodifiers such as anti-rheumatic drugs, methotrexate, and then there's some other modifying agents like infliximab or rituximab. Diagnostic tests would include analyzing the synovial fluid, which would demonstrate the inflammatory process. Again, that rheumatoid factor may not be present. For juvenile rheumatoid arthritis, the onset is usually more acute than the adult form. Systemic effects are marked, but rheumatoid nodules are usually absent. With juvenile rheumatoid arthritis, the large joints are frequently affected, as opposed to the small joints with the adult RA. The systemic form of juvenile rheumatoid arthritis is sometimes referred to as Still's disease, and with these clients they'll develop fever, rash, lymphadenopathy, hepatomegaly, as well as joint involvement. A second form of juvenile rheumatoid arthritis causes polyarticular inflammation, similar to that seen in the adult form. A third form of juvenile rheumatoid arthritis involves 4 or fewer joints, but can cause things like uveitis, inflammation of the iris, ciliary body, and choroid or uveal tract in the eye. Infectious or septic arthritis typically develops in a single joint where the joint is red, swollen, and painful, and there's decreased range of movement. In this, the synovium is swollen and a purulent exudate will form. In some cases, there's a history of trauma, surgery, or spread from some nearby infection, such as osteomyelitis. Bloodborne bacteria, such as gonococcus or staphylococcus, are usually the source of infection. Lyme disease caused by a spirochete and transmitted by ticks is characterized by migratory arthritis and rashes developing several weeks to months after the tick bite. The knee and other large joints are most involved. A vaccine for Lyme's disease is now available. Psoriatic arthritis is an autoimmune form of arthritis that is accompanied by the skin disease psoriasis. There are 5 forms of this disease defined primarily by the areas affected and the severity. So we have symmetric, asymmetric, distal interphalangeal dominant, spondylitis, and arthritis mutilans. The exact cause is not fully understood, but research suggests genetics and other environmental factors. In psoriatic arthritis, symptoms vary in individuals and depending on the specific form, but general symptoms can include swollen tender joints on one or both sides of the body, morning stiffness, swollen fingers and toes, painful muscles and tendons, scaly skin patches that get worse when the joint flare-ups occur, flaky scalp, fatigue, and nail pitting. Additional symptoms of psoriatic arthritis include separation of the nail from the nail bed, eye redness and eye pain, and uveitis. Treatment for this would include NSAIDs, DMARDs, steroids, immunosuppressants, possible therapy. Gout, also known as gouty arthritis, results from deposits of uric acid and urate crystals in the joints that then cause an inflammatory response known as gouty arthritis. This form of joint disease is common in men over the age of 40. Since uric acid is a waste product of purine, normally excreted through the kidneys, hyperuricemia can develop if the kidney excretion is not adequate or if a metabolic abnormality is present. Gout often affects a single joint, such as the big toe. When the acute inflammation develops from the uric acid deposits, the articular cartilage is damaged. Inflammation causes redness and swelling of the joint and severe pain, and attacks can occur intermittently. Atophis is a large, hard nodule consisting of urate crystals that have been precipitated in soft tissue or bone, causing a local inflammatory response. The tophi usually occur a few years after the first attack of the gout. This slide is showing you how the stages of gout progress. So we have this uric acid building up. Okay, symptoms start to occur, causing this attack. We may have periods of remission between the attacks, and gout pain is usually from the tophi in the joints, as you can see the tophi here, which is that yellow area in that big toe. So with gout, we have too much uric acid in the body. The body makes uric acid when it breaks down purines that are found in foods that we eat. Whenever there's too much uric acid in the body, those uric acid crystals will build up in the joints, fluids, and tissues in the body. As the purines break down, they become urate. Urate usually passes out of the body in urine. Uric acid and crystals form because the kidneys aren't excreting properly. So we have inadequate renal excretion here. It can also be a cause of chemotherapy, lysis from the tumors, metabolic abnormality, or genetic factors. The inflammation leads to redness and swelling of the joint and severe pain from the tophi that are deposited in that joint. Normalization of serum uric acid levels is important because uric acid kidney stones are a threat to anyone with chronic hyperuricemia. This is confirmed through diagnosis of synovial fluid and blood tests. Also, no NSAIDs prior to the blood test because they can cause a false negative. Ankylosing spondylitis is a chronic progressive inflammatory condition affecting the sacroiliac joints, intervertebral spaces, and costovertebral joints of the axial skeleton. Women tend to have peripheral joint involvement to a greater extent than men, and it usually develops in people 20 to 30 years of age. It can vary in severity. The cause is unknown. It's considered an autoimmune disorder with a genetic basis. And here we have this chronic progressive inflammatory condition affecting those sacroiliac joints, the intervertebral spaces, the costovertebral joints. All right, what would we expect to see in a client with ankylosing spondylitis? First, the vertebral joints are going to become inflamed. Then we will see fibrosis and calcification or fusion of the joint. This results in ankylosis or fixation of the joint and loss of mobility. Inflammation begins in the lower back at the sacroiliac joints and progresses up the spine, eventually causing a typical poker back. Kyphosis develops as a result of postural changes necessitated by the rigidity and loss of normal spinal curvature. Osteoporosis is common and can contribute to the kyphosis because of pathological compression fractures of the vertebrae. Lung expansion may be limited at this stage as calcification of the costovertebral joints reduces movement of the ribs. Signs and symptoms include low back pain and morning stiffness. The pain is worse when they lie down and can radiate to the legs, similar to sciatic pain. Discomfort is relieved by walking or mild exercise. As calcification continues, the spine becomes more rigid and flexion, extension, and rotation of the spine are all impaired. Some clients, about 1/3, develop systemic signs such as fever, fatigue, and weight loss. Uveitis, particularly iritis, inflammation in the eye, is a common additional problem. The hallmark feature of ankylosing spondylitis is involvement of the sacroiliac joints during the progression of the disease. The sacroiliac joints are located at the base of the spine where the spine joins the pelvis. It can also cause inflammation, pain, and stiffness in other areas of the body, such as the shoulder, hips, ribs, heels, and small joints of the hands and feet. Sometimes the eyes are involved, known as iritis or uveitis. Okay, other inflammatory joint disorders. Bursitis, this is inflammation of the bursae. So those are those fluid-filled sacs like on the elbow that are made to cushion it. It's associated with bones, muscle tendons, and ligaments of various joints. So these bursae are these small fluid-filled sacs that act as the cushion at or near the structure of the joint. Most common causes of bursitis are repetitive motion or positions that physically irritate the bursae at a specific joint, like laying on the concrete floor on your hips. If they have bursae in them, that will really aggravate them. Other actions could include things like throwing a baseball repeatedly or washing the floors frequently on your hands and knees. Diagnosed by physical examination, the joint appears swollen, red, achy, or stiff, and there's pain with movement of the joint. This can include imaging like ultrasound, MRI, and analysis of the fluid in the bursae to detect any underlying problems such as infection. Treatment would be things like rest and anti-inflammatory drugs. Synovitis, which we talked about earlier, can also occur. Synovitis is inflammation of the synovial membrane lining the joint. Movement of the joint is restricted and painful because of the swelling as the synovial sac fills with fluid. The joint becomes swollen, red, and warm and can be diagnosed by analyzing the synovial fluid for signs of infection or crystals which may indicate gout. Treatment would be anti-inflammatory drugs and identification of and treatment of the underlying cause. Tendinitis is the irritation or inflammation of the tendon, characterized by a dull ache at the site of tendon attachment, tenderness, and mild swelling. It can be caused by a single sudden trauma and is more likely the result of repetitive motion or action. Diagnosis is completed by physical exam. Treatment would be things like rest, application of ice, pain relievers, anti-inflammatory drugs, or physical therapy. That concludes this lecture.